Welcome to Gastroenterology. We are going to see images here of things the human eye has never seen, things the human soul has never perceived. We're going to wrap it up all together. Anatomy, physiology, pathology, physical findings. Yeah, the first thing is abdominal tenderness and guarding, rebound, rigidity. Well, when you look at all these, let's get a very clear idea of these physical findings. These all have to do with your peritoneum being pissed off. And don't mix up your peritoneum, which is this thing, with your perineum. That's underneath, you know what I mean? So, therefore, never walk up to somebody you like and say, gee, would you like to help me examine my perineal tenderness? Say peritoneal signs, because that's what those are. Guarding, I may dwell, don't touch me. That's guarding. Rigidity, tight, tight, tight. They're all peritoneal signs of inflammation. You see, when rebound, guarding, and rigidity are in the abdominal exam or in the question, the most likely diagnosis is peritonitis, and the best initial test is, and the therapy is, our standard questions. And the way to do well about understanding human disease is to say, I don't know which thing will be required of me. Let's know all of them. So rebound tenderness means as you press the abdomen and as it pops back out, it hurts. Oh! As you press in and it, pow! Press in and, ow! That's rebound. That's rebound. I had appendicitis. I had this. I will now act out all of them. I won't tell you where I went, but I got to tell you, it hurt. It was the worst pain I'd had at that time. I had to have my appendix out, and I really didn't appreciate things like this. I was like, I had all of these. And the nurse comes by, and the doctor comes by, and they go, look, you're just a case of simple appendicitis, okay? We have sicker people here than you, all right? You like that? You ever been to a restaurant like that? Oh, you're hungry? Really? Well, we have people here who are hungrier than you. Wow. You wouldn't go to that restaurant again. Rebound tenderness means that you press on it, and when you release it, the release moves the peritoneum, and it really hurts a lot. Guarding means, touch me again and I'll kill you. It's like Die Hard. Hey, examine my abdomen again. Examine my abdomen again and I'll kill you. That's guarding. Guarding means that you grab the examiner's arm because it hurts. There should be another way of saying this, like, don't touch me, that hurts. And rigidity means that it's so tender you can't even press on it because all the abdominal muscles are contracted into a rigid board. Now, all of these findings are signs of peritonitis and inflammation of peritoneal and abdominal organs. The other part about them is, particularly rigidity, is that when I was I'm just saying this to tell you that it's not like it's a million years ago, but even up until the time I was a medical student or resident, they used to say crazy things like, don't give pain medications to an acute abdomen because you'll mask the findings. Because we used to have to rely on these findings to determine who to operate on. Now we can scan people. Doesn't that make you feel grateful about all the cool things we can do? That you don't have to wait till rigidity happens to know that you need to take people to the operating room. They all mean severe disease. They all mean you need an abdominal CT scan. The best initial test for all of them, okay, if it's for air under the diaphragm, and only air under the diaphragm, or an ileus, small bowel, stopping working. Ileus, small bowel paralysis, is an abdominal x-ray. Air under the diaphragm is a chest x-ray. Plain films, chest x-ray looks for perforation, air under the diaphragm, and abdominal x-rays look for ileus. Other than that, plain x-ray is a very, very inexact way of confirming your diagnosis. The abdominal CT scan is useful a lot, and that's the way you're headed. So these findings, we rarely get to rigidity anymore because we can image it. Rigidity is a sign of untreated impending perforations. These signs all indicate the need for immediate surgical intervention to repair or remove the perforation or the site of inflammation. So, let's be clear about these ones again. Guarding. Don't touch me, I'll kill you. Rigidity. Rigid, board-like abdomen. The worst. Go to the operating room now. Rebound. When you release it, it hurts even more. Peritoneal inflammation. What is this? Ooh, looks like pregnancy, but it's not. This is ascites. What's the most accurate test of this swollen abdomen with ascites? And the therapy. How do you know which one of those questions will be asked? You don't know. It's ascites. It is extravasation of fluids through the liver and through the intestines, and it occurs secondary to hepatic and cardiac disorders which make the liver swollen and make either portal hypertension, hydrostatic pressures, transudate fluid across the liver. Hydrostatic pressures, transudate fluid across the liver. Exudate is cancers and number of infections. CHF results in transudate, low protein, low LDH, low protein, low LDH across the liver. Cirrhosis is a source of portal hypertension. Portal hypertension is the portal system which is made up of the portal vein and the splenic vein. The portal vein and the splenic vein. The portal vein, when the liver gets fibrotic, has hypertension, it extravasates and leaks fluids across it. Now, liver, pancreas, and ovaries and peritoneum all cause ascites, but liver, pancreas, ovarian, and peritoneal what? What? Liver, peritoneal, usually cancer. Cancer, Meags syndrome, but cancer is a cause of exudate. Cancer is a cause of exudate across the liver, across the peritoneum, across the pancreas. Paracentesis obtains fluids for the albumin level, and this is one of the main ways. Now, this word was not clear to me when I was in medical school. Why do I call it paracentesis? Why not call it peritoneocentesis? Right? Peritonesis, peritoneocentesis, but paracentesis means we're putting a needle inside the abdomen in through the peritoneum to take out fluid. That's what paracentesis means. And paracentesis is done to see if you have fluid albumin that's high or low. Paracentesis tells us if the fluid albumin is low, it's a transudate. Low means less than 50 or 60% of serum, or the LDH. And when you have a low acidic fluid, low acidic fluid albumin, when the difference between the serum and the ascites, between the serum and the ascites, between the serum and the ascites, when the difference is more than 1.1, this is a transudate. The SAG, the serum to ascites albumin gradient. The serum to ascites albumin gradient is one of the most important things. Scratch that in ascites. It is the most important thing that you could know to know what's the etiology of that fluid, man. What's the etiology of the fluid? Transudate portal hypertension, CHF, has a high SAG. Thank you very much. Portal hypertension. And the other thing is SBP means spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is that you don't know where the bacteria comes from, but bacteria have gone through the peritoneum and are causing you to have an infection inside your peritoneal fluid, and we don't know where it comes from. That's why it's called spontaneous, because it just happens. 250 neutrophils is the definition of spontaneous bacterial peritonitis. So SBP means here ceftriaxone, cefotaxime. So the two take-home messages you have to get is that when you see ascites, you have to tap it. You have to tap that ascites because you have to know whether that ascites, you have to know whether that ascites is a transudate or an exudate. Exudates are cancer, transudates are CHF, and portal hypertension. You have to know if it's infected, SBP, because you're going to give antibiotics. And the treatment in general for ascites is with spironolactone. Now, spironolactone is an aldosterone antagonist. Spironolactone is an aldosterone antagonist, or eplerenone as an aldosterone antagonist, because it decreases the ascites. Regular loop diuretics too, like furosemide, but spironolactone is specific. Ceftriaxone, cefotaxime. Liver metabolized, kidney metabolized. Liver metabolized, kidney metabolized. Liver excreted, kidney excreted. Liver excreted, kidney excreted. Very step one, pharmacology. What's the mechanism of excretion? So this is a picture, what you see right here. This is basically saying when you have portal hypertension in the liver, you have the extravasation of fluid and ascites, and that extravasation of fluid and that ascites, that happens from portal hypertension. The portal hypertension causes you to have transudative fluid. Oh my God, look at that. That's a big belly, man. That's a big belly. And that big belly there is happening from ascites. And here is the ascites as well. That big belly is ascites. That big belly is ascites filled with it. That's why paracentesis has almost no complications, because at paracentesis, Helen Keller could get this. Get a piece of that. That was terrible, isn't it? And you see, is the serum to ascites gradient high, greater than 1.1? Portal hypertension. Now, portal hypertension is from it has splanchnic vasodilation and decreased circulatory volume. Well, this is because if the fluid is extravasated into the ascites, it's not in the blood vessels, is it? If the fluid is extravasated into the ascites, then it's not in the blood vessels. So it's a decreased circulating volume. Next, when you have low intravascular volume, you have a high renin. High renin is detected at the afferent arteriole. Low volume, afferent arteriole, you make more renin, the juxtaglomerular complex. That makes angiotensinogen convert to angiotensin 1, to angiotensin 2, to the zona glomerulosa, my friends. The zona glomerulosa makes the aldosterone. So you shouldn't walk into any test in medical school without you knowing this with the naturalness of you being able to take a fork or a spoon of food, and you should be able to put it in your mouth without poking yourself in the eye with a fork. Decreased intravascular volume gives a high aldosterone state, and now you know why we use spironolactone. Because spironolactone is an aldosterone antagonist. And we use an aldosterone antagonist because we see high aldosterone levels. Renal sodium avidity means that the kidney perceives low vascular volume, and so what ends up happening is you absorb a lot of sodium from the urine, and that's also what helps make the ascites. Increased renal sodium avidity sucks up sodium and causes you to have fluid overload in third spaces like the peritoneum. Now, a renal vasoconstriction, we don't really know why hepatorenal syndrome happens. We can't really say why hepatorenal syndrome happens. We know that hepatorenal syndrome is the numbers that are for prerenal azotemia. We know that hepatorenal syndrome is the prerenal numbers, urine sodium low and high BUN and creatinine ratio. But if you take these kidneys out of the patient and you transplant them into someone else, they'll function normally. So hepatorenal syndrome, we don't know what to do about it too much. We give albumin, we give terlipressin, which is like vasopressin, midodrine, an alpha agonist, but we don't really understand it, except your big take-home message is hepatorenal is liver failure leads to kidney failure. Liver failure leads to kidney failure. All patients with liver failure and cirrhosis have a low intravascular volume. That low intravascular volume gives them a high renin-angiotensin aldosterone state. This is I like big guts and I can't deny it. This is, see all those blood vessels there on the surface of the skin? All those blood vessels on the surface of the skin is also known as caput medusa. This is a portal to systemic shunt. What do you do for portal to systemic shunts? Well, if there's ascites, you diurese off the ascites. What do you do if there's a vascular blockage? Try and unblock it. Now, in the past, 30 years ago, we used to do surgical shunting from the portal vein, to the systemic system. But portal systemic shunts placed by surgery are very complicated because they have all sorts of adverse effects, like bleeding to death, that's sort of an adverse effect, and encephalopathy. So a caput medusa is just one type of portal systemic shunt. The other is hemorrhoids, and the most important is gastric and esophageal varices. Caput medusa, the head of the medusa, is caused by portal hypertension in the veins between the umbilicus and the thorax. The veins between the umbilicus and the thorax, the thorax and the umbilicus and the thorax. And it's a portal systemic shunt. And the blood is shunted through these abnormal veins to try and decompress the portal system. Basically, you're popping open vessels that had remained closed since embryonic circulation stopped. It's really popping open some embryonic circulation here to decrease portal hypertension. And the treatment is to take a catheter and poke a hole in the liver. If you have those portal systemic shunts to the point where you bleed, you need to take a catheter and poke a hole in the liver so you can open it up and decompress it. Besides bleeding, what do you think the most common adverse effect is of taking that catheter and creating that shunt? What do you think the most common adverse effect is? And the answer to that is encephalopathy, because the liver should detoxify the blood. But if you poked a hole in the liver, how can you detoxify your blood? How can you detoxify your blood if you're bypassing the liver? And although it decreases portal hypertension, transjugular intrahepatic, transjugular intrahepatic, transjugular intrahepatic portal to systemic shunting is a standard of care for massively bleeding varices and to decrease this portal hypertension. Transjugular intrahepatic, poke a hole in it with a balloon. Surgical shunting, rare. Surgical shunting, dangerous. Surgical shunting, last resort. See, the ascites is treated with diuretics. Furosemide, bumetanide, indapamide, the loop diuretics like furosemide. And the specific one is spironolactone, because spironolactone decreases the aldosterone that is high in cirrhosis. I know that many of you get taught of spironolactone as a potassium-sparing diuretic because that's what it was invented as. Spironolactone is an aldosterone antagonist. We use it for congestive failure routinely, and we use it as a diuretic only in portal hypertension. Only in portal hypertension. That's the only time it's useful as a diuretic. So if you get taught it predominantly as potassium-sparing diuretic, let's send an email to your faculty to say, why don't you buy them a calendar and tell them it's the 21st century. Hi, it's 2000 and blah, 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 year. Open the can, you know? So this is the portal vein. And the portal vein is made up of the gastric veins, not coronary vein like coronary of the heart, but the gastric veins, the splenic vein. This is why you get big spleens. This is the mechanism of why it is that cirrhosis and portal hypertension causes a big spleen. That's the mechanism of the big spleen with portal hypertension. Remember, 80% of the blood flow to the liver is the portal vein. There's the anatomy. This is a critical anatomy question. And also the other thing is that this anatomy question is not in the standard flashcards. The standard flashcards are a basis to have something in your hands. But what we're doing here with the basic science part of the flashcards is to add you the anatomy, physiology, and pharmacology. And so when you mix up the superior mesenteric vein and the inferior mesenteric vein, superior mesenteric vein draining the colon, the inferior mesenteric vein draining the other part of the colon, you see here that the portal vein is made up anatomically of the splenic vein, IMA, SMA. Splenic vein, portal vein is made up of splenic vein, IMV, and SMV. The mesenteric veins and the splenic veins. And this is portal hypertension. 80% of the blood flow is from the portal vein. That portal vein thrombosis, what is this? Ooh, big, strange things. Hepatic vein and portal vein thrombosis. Come to think of it, I'll have a bud. Bud what? Bud Chiari. It shows you why when you have portal hypertension, why your spleen gets big. Because when you have a cirrhotic liver that's all tight, fibrotic, it makes the spleen really big. Tight, fibrotic, makes the spleen really big. Portal hypertension. Tight, fibrotic, cirrhotic, it makes the spleen really big. Because the portal vein is made up of the splenic vein, the inferior mesenteric vein, and the superior mesenteric veins. And that's why this is a picture of a TIPS procedure. You take a catheter, put it down the vein, and pop a hole in it. And it makes it so you have portal to systemic shunting. Transjugular, intrahepatic, portal, systemic shunting. Portal, systemic shunting. The TIPS procedure. I like to balloon it. You like to balloon it. We like to balloon it. And open up the liver. Next card. A 64-year-old alcoholic man comes with discoloration of his hands. And what is in these discolored hands? What's the test? Ooh, is it the test? Is it the diagnosis? Is it the treatment? Palmar erythema is from liver. Discolored hands and liver dysfunction is because the palmar erythema results from excess estrogen. Why does estrogen make your palms red? I don't know. I know a lot of ladies that have a lot of estrogen and they don't have palms that are red. And it causes a red discoloration of the palms. Yeah, it causes a red discoloration of the palms. There's no direct test for palmar erythema, red discoloration of the palms. It's just a physical finding of cirrhosis. That's all. There's not that much to it. It's just like this. You're saying all I need to know is that when I have cirrhosis and my liver is dead, my palms turn red? Yes, that's all you need to know. Oh, okay. So the test of liver function test is prothrombin time, because ultimately the clotting factors are made almost all in the liver. All clotting factors are made in the liver with the exception of factor 8 and von Willebrand's factor. With the exception of factor 8 and von Willebrand's factor. With the exception of factor 8 and von Willebrand's factor. Prothrombin time, therefore, is the single best test of liver function. If your prothrombin time is normal, it means that the liver, no matter how bad it may seem to you, is still working enough to make clotting factors. No matter how bad it seems, it's working enough to make clotting factors. Prothrombin time is normal. The same way, if I told you your liver function tests, AST, ALT, AST, ALT, AST, and ALT are normal. Ooh, but the prothrombin time is up. The single greatest test of the functionality of your liver is your prothrombin time. Because transaminases can be normal. If you came to my bathtub, would you find any hair on my bathtub drain? You wouldn't. You wouldn't. You wouldn't find any hair on my bathtub drain. And you say, oh, look, Conrad, he's got such nice, healthy hair. He's got no hair in his bathtub drain. And you go, you're right, he's not losing anything. It looks like transaminases. You got to have something to lose something. So if your liver is all the way dead, you can't make transaminases. If your hair is all the way gone, you don't have hair building up in your drain. Functionality. Prothrombin time tells you functionality. Remember, there's no direct therapy for pulmonary erythema. It's just a physical finding. The blood supply to the liver, the portal vein, is made up of the superior mesenteric vein, the inferior mesenteric vein, and the splenic vein. The portal vein, superior mesenteric, inferior mesenteric, and splenic vein, it explains why cirrhosis equals splenomegaly. Why does cirrhosis equal splenomegaly? Cirrhosis equals splenomegaly, and hepatic artery is only 20%. And that's a very unique structure, by the way. It means that the liver is a structure whose predominant oxygen and nutrient supply is from a vein. Well, isn't that a good question? What organ has its major oxygen supply from a vein? Wow. That's unique. That thing, what's he feeling? What is it that he's feeling in there? That bulb there. The most accurate test in the therapy. What is he feeling, and how are you going to diagnose it? He's feeling the gallbladder. Beautiful picture, isn't it? He's feeling the gallbladder. But the gallbladder shouldn't be big enough to poke up like that. The gallbladder is squishy and soft, mushy. It should be like a half-inflated water balloon. So the gallbladder should not be popping up like that unless it's too diseased with cancer to be squishy. That sign is Courvoisier's sign. It's a painless, palpable gallbladder. It's a painless, palpable gallbladder from gallbladder cancer or something called cholangiocarcinoma. And cholangiocarcinoma is the bile duct cancer. Histology, histology, pathology, histology, pathology, histology, it's adenocarcinoma. The painless, palpable gallbladder that goes with gallbladder or cancer of the bile ducts. When you have cancer of the bile ducts called cholangiocarcinoma, some people used to call that a Klatskin tumor. When you hear the word Klatskin tumor, it's cholangiocarcinoma. It's painless, palpable gallbladder because it's not infected. That's why there's no pain, no tenderness, and no redness. Doesn't that suck? But that's Courvoisier's. Painless jaundice. The abdominal CT is what you do first, abdominal CT or sonogram, but because it's pathology, remember, for cancer and infection, biopsy is always the most accurate test. For cancer and infection, biopsy is always the most accurate test. For cancer and infection, biopsy. That's the painless. This is a beautiful picture, isn't it? Here's a pancreas, the biliary system, the artery, the vein. Ooh, let's just absorb that for a second. It's so gorgeous, isn't it? Anatomy. Anatomy also diagnosed with scans. That's how step one is going to test you. It's going to test your knowledge of anatomy by saying, do you understand that that's the gallbladder, that's the liver, that's the kidney back there, there's a pancreas there, that's the gallbladder. This is histology showing you normal gallbladder. Oh, look, we have some mutations. We have some mutations that tell us that we're about to have cancer. Dysplasia wants to become cancer. Dysplasia wants to become carcinoma in situ. Carcinoma in situ wants to become invasive cancer. here's our pathology histology. Dysplasia at the cervix wants to become carcinoma in situ, wants to become invasive. Dysplastic polyps want to become cancer. So this is the histology that says dysplasia is premalignant for sure. Now, hyperplasia is a pathologic finding that's not dangerous. Hyperplasia is not dangerous. Dysplasia is. So epigastric tenderness, what are we going to do with that? Here, right there, right there, right there, right there. Right under the xiphoid, right under the xiphoid. When you see epigastric tenderness, what's the diagnosis when it's epigastric right there? Right there? Ooh, okay. And the most accurate test for epigastric, right underneath there? So epigastric tenderness is pain on palpation just under the xiphoid, just under the xiphoid, right there, just under the xiphoid. Gallbladder is not really quite there. Cardiac things are not tender. The most likely diagnosis is pancreatitis, and you should gain increased amylase and lipase. Ulcers are rarely ever tender. Ulcers are pain without tenderness. Pain without tenderness. Ulcers are pain without tenderness. And duodenal ulcer too, pain without tenderness. And this thing about worse with food for gastric ulcer, better with food with duodenal ulcer is only an approximation. You can't make a diagnosis off of just better with food, worse with food, better with food, worse with food. But the tenderness, does it hurt when I press? That is really important. Pancreatitis, amylase, lipase. Now, cholecystitis is more on the right. Murphy's sign is more on the right, up here. Murphy's sign is more on the right, up there. So reflux disease and gastritis, they cause pain. They cause heartburn. They can cause heartburn, but they're not tender. First of all, it's very hard to have tenderness of an organ that's underneath your sternum. Number two, even if you could press on it, it's inflammation, but it's not tenderness when you press. Tenderness when you press is pancreatitis. Now, the most accurate test for these are pancreatitis. The most accurate test is a CAT scan, especially for acute disease. And you can only diagnose ulcer disease with scopes. Ulcer disease ultimately is diagnosed with a scope. Barium's not great. Barium is okay, but barium in the esophagus is okay. Barium in the stomach is crappy. And when we're looking for cholecystitis, sonogram and CT will show you there's stones. Sonar or CT will tell you there's stones. The HIDA scan tells you functionally non-visualization of the gallbladder. This HIDA scan would tell you functionally there's cholecystitis. Now, pancreatitis. That's the pancreas over here. This is the pancreas over here. That's intestines and omentum. Liver, kidney, 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 liver, kidney. This is pancreas. That pancreas is about 3 times bigger than it should be. It also shows it to be big, inflamed, and gooey and edematous. The dark is the edema. Pancreas. The dark is the edema of the pancreatitis. Gallstones in the gallbladder. Isn't that amazing? Why are they down at the bottom? Because the person's lying on the table. Why are they down at the bottom? Because the person's lying flat on the table. Kidney, liver, pancreas. This is an ecchymosis of a person's flank. This is blood in the flank. Now, when you see blood in the flank there, and you see this ecchymosis of the flanks or around the umbilicus, this represents retroperitoneal hematoma. And retroperitoneal hematoma is associated with pancreatitis, necrotic and hemorrhagic pancreatitis, and it's associated with pancreatitis because when you turn the person, this is how you think of it. Gray Turner. How do I know it's the one on the side? Because you turn her. I turn, and I see it on the flank. That's Gray Turner's. What's the one around the umbilicus? That's Cullen's sign. That's the one around the umbilicus. That's Cullen's sign. So these are all signs of retroperitoneal bleeding from necrotic hemorrhagic pancreatitis. And they're both associated with the need for going to emergency CAT scan and the operating room. Gray Turner's and Cullen's sign. Gray Turner is on the flank. Cullen's sign is on the umbilicus. They both mean scan that abdomen and go to the operating room. Now, if you have more than 30% necrosis, we should biopsy you. Because 30% necrosis is severe, and also that's the number that we use, our magic number, for determining whether you should see if it's infected necrotic pancreatitis. Because infected necrotic pancreatitis needs surgical debridement. You cannot fix infected necrotic pancreatitis just with imipenem and fluids. Infected necrotic pancreatitis needs surgical debridement and clearing up. This is another Gray-Turner sign and Cullen sign. Gray-Turner sign and Cullen sign, because this is a person with an extremely severe necrotic pancreatitis, and this is a pathologic specimen of the same extremely severe necrotic pancreatitis, and this is a CT scan of the extremely severe necrotic pancreatitis. How do you know which one you get? Will you get this, the physical finding? Will you get this, the pathologic specimen? Will you get this, the anatomic picture? Who cares? Now you're prepared for all of them. Bring it on. Then a cup and dejo, I'm ready for anything you're going to ask me. Is that the hardest questions you can ask me? Come on, bring it on. Make them harder.